All right, good morning everybody, and thank you for getting up early and giving us some of your time. Welcome to the Iridex Transscleral Cyclophotocoagulation talk as a procedure for failed MIGS. So as we know, there's a lot of procedures out there that we can choose for our glaucoma patients. But more so, it's about options when you have things that fail. And we think that this is a perfect technology to introduce at kind of a lot of paradigms along the way in terms of other failed procedures, MIGS being one of them. So I'd like to introduce Dr. Mahootchi from Zephyr Hills, Florida, and Dr. Jella An from Columbia, Missouri, who are our speakers today. They hold a wealth of information and a number of different types of treatment paradigms that they use this technology in. So as they present, we do want this to be very interactive. We want it to be very real world, and so please feel free to raise your hand and ask questions, and let's make this as important as possible.
All right.
Thank you.
Thank you. Thanks for coming, and thank you, Iridex, for having me. I'm in the Tampa area, Tampa, Florida. I've been there since 1996, whatever years that is. So we'll talk about how many of you are currently doing MicroPulse? So good. Anybody not doing MicroPulse? I'll give you the basics and how I traditionally use it, and then we'll get to the title. So that's my actual machine, the non-sexy procedure. So as you may or may not know, the Cyclo G6 with the P3 probe is what we're talking about. I've always called it Cyclo G6. That's just for short because it's kind of a cuter name. But it's non-incisional, non-destructive, not your grandfather's cyclodestructive procedure. And I think the key for me, I probably walked by the booth 1,000 times until somebody told me, it doesn't work the way you think it is. And I'll tell you what flipped me. There's really minimal inflammation, unlike traditional cyclodestructive procedures, and there's a much more broad use than end-stage glaucoma. And I'll be honest, I almost never use it for end-stage. I'm just a different animal. So it's, I remember one of the older Iridex reps told me at an ESCRS meeting, like, this is a outflow procedure. That changed how I understood it. And then over the next couple of years, we saw more science that shows that it works maybe as an inflow to a little bit, but as largely as an outflow procedure. And that was a big break in me understanding that if you think about it differently, all the sounds and motions and the way you think about it changes when you see it as a non-destructive procedure. And then for me, a big break was thinking that, well, this is, if it's not to be used at if you can use it at the end, but if you use it for a broader selection of glaucoma patients, there's 1,000 uses that you may or may not have thought about. And so we'll get to some of those. It's not cyclodestructive light. This is just a different animal. So it actually takes less than 3 minutes per eye, and I'll show you how to do it right, maybe how to do it wrong as well. It's got a really benign post-op course. The first time you do something, you see it the first day. But for mild, moderate, which is when I'm using it most of the time, I found that I'm not learning anything the first day. I'm actually not learning anything a week later. It turns out 80% of people who are going to respond, and I'll steal my thunder, about 92% of people will respond by having less drops or less pressure. 80% of those will be there at 3 weeks. 100% of that 92 will be there at 5 weeks. So I don't even bother checking until 5 weeks. And what I do is I typically will use, I'll stop, since my goal is to stop one drop usually, I'll stop one glaucoma drop at week 1, and I'll stop my steroid drop at week 2. And I use loteprednol, one of the generics or one of the cheaper ones. So I'm not confusing steroid response with the effect of my surgery. So I'm just kind of, when they come, this is purely, did it work or did it not? And it does 92% of the time. Thank you very much. Good night. And it's probably another breakthrough for me is that it can really be done in the office or the ASC. I do it in an ASC. And it's got a long established billing code. So let's face it, in Florida, 40% of people have insurances that don't cover MIGS. So they've traded their Medicare for a Medicare Advantage plan. Probably for in California, it's the same way. And so you can't do hydras, you can't do iStent. So it becomes my primary procedure. and it can be mixed with other things like goniotomy, depending on whether you want a lower pressure or do you want a low pressure. We'll talk a little bit about those. Probably the biggest thing that changed from my place, the way that I do it differently than other people, is whether you do it with a block or not. I don't really block a lot. So we had a one-eyed patient want to do this treatment for, she can no longer put the drops in. And she can't stop her blood thinners, so we do this. I'm like, well, why don't we just use, my anesthetist came up with just using less Versa than we use for cataract surgery, some fentanyl right before the case, and then propofol, but of such a low dose that it gets you through the case, but they don't linger in post-op. So, why do a 3-minute case if they're gonna hang out in post-op for an hour? So we don't do that. These guys are up and out in about 20 minutes. Then I thought, if I'm doing it for one eye, why don't I just do it for both eyes? That's kind of a change. So now I think Iridex was a little bit worried. I think the first time the rep came, we did 22 cases on the first day. And I'm like, what are you doing? But chances are, if you've been in practice you have hundreds of patients who don't like their drops or can't afford some other option or can't do another option. And this is like a procedure that allowed me to treat a bunch. It created a new market. I wasn't robbing one set of procedures to do it. It actually grew my practice. And this is started like I can do it at the time I'm doing other procedures. So I do it with cataract in that case. But if you're doing a ptosis repair on somebody who's on latanoprost, that's a side effect of the prostaglandin analogs. Why leave them on the thing that's going to undo your surgery? So we would, if I'm doing a plastic procedure, I would do it, just get them off the drops any other time, and it really added minimal time to the case. And you did it on, I have done it on open angle ocular hypertension, low tension glaucoma, even if they can't do the drops, and chronic angle closure. I haven't done a lot of uveitis ones. I don't think it generates a lot of inflammation, so my concern really isn't there. But I guess I don't have a big population of it. And I've done teenagers, but I haven't done kids. This is right after the procedure. Okay, so there's no block, and
yeah,
she's
we're
asking
already
me,
done with it.
did I actually have it done?
That's great. So didn't feel it.
And
Didn't
she's
remember
90,
it. That's
and you can tell she's a little red when I've run.
So we're hoping to get you off your medicines and
It's
get that pressure down.
phenomenal for your older
All right,
patients.
great.
So
Any
we
questions?
Tore through about 200 patients the first year. And then it's become like a routine thing. I do it every week on 200 patients. So that was the wow. Okay, they're not blocked. She's gonna walk out of here. She's older. This is a game changer for me for glaucoma. In case you don't know how MicroPulse works, it's not just turning the power down. It's delivering in such short time intervals that you don't really generate a lot of tissue heat, so the tissue relaxes before delivering the next pulse. So you can't do that with continuous wave. In the retinal, I'm a type 1 diabetic, and I originally got interested in Iridex because if I was going to have a focal, I would want to have it done with something that doesn't leave a burn. And so I have a bias. Here in the retinal world, we're doing a 5% beauty cycle. We're doing a little bit higher at 30%. And it looks easy, but it's still important to watch the details of what you do. That there are pearls in the technique, and I will say that a good idea is to work with your Iridex rep. It'll show you how to do it right and how to do it wrong. And I'm going to show a video of me teaching other people how to what I think is right, which is actually wrong, from a few years ago. But you'll be your own worst critic. Have your friends or nurse take a video of you with the iPhone of doing it, and you'll see that it's not actually. It's easier to do it wrong than you think, and just paying a little attention to detail is going to make you spectacular and fast at it. I would suggest, because there are people who thinking that it's cyclodestructive, they're going to hold it in one spot. Do not ever do that. You will create some really bad problems. You'll damage cons. You might make it harder to do an incisional surgery later. You're burning stuff that you don't need to do. Don't do that. But don't really vary the power ever. I don't vary the duty cycle ever. Initially, we were varying the time some, And I'm not somebody who's like a really bad glaucoma end stage, I'm gonna do it a whole lot more. I think when you learn that we lose so much of the power when you do it wrong, that if you standardize the technique, it actually becomes shorter and you get a more consistent result. So I in the first 30 cases, please promise me you're not going to vary the time that you spend, maybe the 80 seconds or 90 seconds that they're recommending. But oddly enough, what you do need somebody to keep the tips submerged. If you keep the tips submerged, a lot more of the energy actually goes in the eye, and not a lot is reflected out. And that's how you lose. You know, you have people who do it and they go, nothing happened, or I didn't get the effect I wanted. That's what's happening. You lose an enormous amount of energy. So the suggested mechanisms of action, and I heard it was outflow, was it may make the ciliary body more permeable to fluid. I'm not going to show the slides, but Iridex has a bunch of it on the right side of these little particles that are going through the ciliary body. This ciliary outflow mechanism that's kind of unique. I think Murray Johnson's videos of showing them you're stretching open the trabecular meshwork, so it's kind of working like pilocarpine would. So you can actually see that meshwork opening up without burning or destroying anything. You know, there may be some dual mechanism aqueous production, and you may have a combination, and you can get some pretty good results. So again, my use has been to reduce drops in mild and moderate disease. It's less expensive as a primary choice than iStent or Hydrus, and I've spoken for both. And there's less, I think for me as a glaucoma surgeon, I don't like to operate on red eyes, and I don't like to operate on eyes that are cued for failure. And that means that if they're on 3 drops for a very long time, the conj reacts to any kind of Zen or trab much more aggressively because of the inflammatory cells in there. So I don't usually like to have surgeries that are called planned failures, but in this case, I'm doing it to I don't like people to be on 3 drops ever, because you know it's going to fail. So at some point we do this to get them down to 2, and if you fail a couple years later, then you don't go back and put more drops on. You go to the next step, which would allow you to be more successful. So I will say I'm not a repeater of drops, mainly because it's an older population and maybe they haven't needed it. But I've only repeated 2 out of like 300 in the last couple of years. Most repeat much more than that. So it's fine to repeat. I think if you do it correctly, you probably won't need to repeat as much. And if you are looking for less drops or a lower pressure, like by a couple of points, then this is great. If you're looking for a low pressure, you're looking for something like 12. Mix it with goniotomy, and it's 5.5 points reduction. It's phenomenal, and you can do that easily. Most places will let you build those 2 together. Yes.
Why you don't retreat? I mean, because you don't need.
I haven't needed to. I haven't needed to. Or in some of them, I treated it because they were on 3 drops, and I know I need a low pressure to something like 10, and I'm just trying to get the conj quiet for a few months or a year before I need to do that. But half the time, you don't need to do it. So sometimes you just knock it out of the park, and you don't need to do it again. But I'm not doing the red eye at pressure 56. And I think as you're seeing at the glaucoma meetings, that's what they're talking about. That's a pretty narrow subset of patients, and my patients are not sick enough. Hers probably are, but and I'm not a university, I'm just in private practice. So, we talked about the post-ops. I mean, I'm seeing them at the time of the surgery and 5 weeks later. Unless they have moderate or severe disease, don't be a cowboy. If they've got bad disease, you might want to check them sometime earlier than that. But for most mild to moderate, you're not learning anything even at week 3. So it takes 5 weeks to work. So here's a case of this is not in failed MIGS, but this is where I would have failed. This is a 66-year-old white lady who is a controlled schizophrenic with diabetes, never goes to the eye doctor. And so she comes in and she's got cup to disc of 0.6, IOP of 20, and her visual fields are, we'll see, she's cleans her own RGPs in her own spit. She's counting fingers vision, and corrects the 20/70 with her big myopic shift. So she can't take the beta blockers due to depression. and she's already having trouble feeling her lows. I don't like using prostaglandin analogs around the time of cataract surgery. And affording the medicines and actually taking them or following up, I knew she wasn't going to do it. So her field's not terrible, right? Some mild inferior stuff. Her ganglion cell is awful. This is the contact lens doing it, so I got her to stop cleaning it in her mouth and stop wearing them all together. And so she needs cataract surgery. The compliance is going to be awful with glaucoma drop stuff. And she's oddly, remarkably clear that it's more important to be spectacle independent than it is to be drop independent. So she's really clear about that. So she can't afford glaucoma surgery iStent and can't afford a toric lens at the same time. And I don't charge a lot for torics. So we plan on doing the cataract surgery with a toric IOL and Cyclo G6. There's not an implant cost when you do it. And I used intraop Trimox with some cheap Control-like afterwards. And we do Cyclo G6 back then, 90 seconds per hemisphere, always leaving 3 and 9 spared. And then we proceed, and she's 20/30 unaided now. She went from 20 to 12 off drops for 6 months or more. It's actually, I've used this a couple times. She pops in and out of my life every year or less, and she's still great. This is like 3 years old now. This is how I used to teach people to do it, and it is dead wrong. There's no fluid. I'm not underwater. You should be underwater. And as perfect as you think about sliding around, I don't use a speculum anymore. You'll see that you're not always, if you don't pay attention to details, you can get in trouble. In fact, any kind of time I see the pupil stuff with it, it's because I was riding high. I go back and watch the video, and I was riding high. So you don't be too low, don't be too high, just be just right. Follow Kevin's a little card, maybe put it on your machine, and that's how I used to say was the right way to do it, and it's clearly the wrong way to do it. So there's what we're talking about today. 2015, this guy's on 2 drops for his glaucoma with a pressure of 18. Do cataract surgery with iStent, and he pays the 20% of the insurance of the iStent markup or the copay, and afterwards he's on 1 drop, IOP of 16, but it had been creeping up from 13 post-op, and then in 2017 he's back to 19, and he's underwhelmed. Why did I put in that iStent? Why would I even pay you to do another procedure if you recommended something that didn't work the first time? And we add a second drop back, and his pulse starts to slow, so people don't always have the reaction to the drop that they're going to have initially. It can be years later, so you have to remember to keep checking. And so 2019, I do Cyclo G6, and 5 weeks later, he's IOP of 13 on 1 drop, and I haven't had the guts to stop another drop yet, but he's 13 a year later. I had this giant database where I just would check their pressures and see what happens. So it's durable. About 92% of people will respond initially. At a year, it'll still be 90. It drops off. Probably by year 2, it's like 83 or 84. And then 3 years out, it's still above 70. I had asked Nathan Radcliffe one time, well, how good does this work? Or actually it was for side passing. It works about as good as anything else in glaucoma, which is super disappointing to hear. But that's pretty darn good. And if you've done it now, you're queued up for success because you haven't exposed the conj to a bunch of to a bunch of drops. So last one, 68-year-old guy with side pass. He's on 3 drops for his glaucoma with pressure of 23, and redness is becoming an issue, and ptosis. Summer of 2017, I do cataract surgery with side pass, and he's initially in the mid-teens on 1 drop. By early 18, he's 2,000, he's up to 20, but the visual fields are progressing, and I'm having to have the drops back. And then there's the bad news about side pass. I have to fortunately, he didn't have any endothelial problems then, but maybe kind of early. He just does not. The eye drops are not working for him, and I would love to do Zen on him, but his eye's primed for failure. You've got a red eye on 2 or 3 drops. You're high risk of having to explain to him why my recommended treatment didn't work. So I did Cyclo G6 on him to get him down to 16 in a quiet eye. I wanted him lower than that, so I did an ab externo Zen 4.5 months later, and no problem at all. So that's it. I think there's 1,000 different uses. You can do it with other procedures, without other procedures. I guarantee you each one of you has hundreds of patients who are candidates for doing it, who want an option other than drops, but don't want to have something done inside the eye. And with some little help from your anesthetist, you can, it's benign enough that you can do both eyes at the same time and do very, very well. Thanks. Ask me questions in detail later if you want.
While we're just getting set up for a second, one point that Dr. Mahootchi made about the liquid interface is imperative in that this is not an optional part of the procedure. So there's a true engineering reason why you have to have the probe in a liquid interface, and you have to maintain good coupling with the tissue. Otherwise, as he mentioned, you're going to lose up to 45% of the energy before you even get to the conjunctiva. So it's imperative that we recommend a viscous substance, a methylcellulose, a goniosol or gonioscopy type fluid for that interface, because it'll allow you to have better coupling, plus it will aid in the moving back and forth over the conjunctiva. But on top of it, there's also some pressure involved. So you want to maintain, at least like a pen to paper type pressure along with that liquid interface, so you can transfer as much energy as possible to the desired tissue. And so it's not optional, it's a mandatory part of the procedure.
Have you considered or worked on developing any type of aid or an appliance placed on the eye that you could move around so that you could keep the angle proper? And it seems to me that one of the reasons I'm here is because I think this procedure is so technique dependent that it's getting minimum reviews because we're not doing it right.
Yeah.
And it's trickier. And so I just wondered whether or not there would be some sort of aid that you could put on the eye that you could then run it around or couple it.
In the last year has invested a lot of money into trying to bring the 9 variable points of the technique right now down to really like 3 or 4, which would just be power, duration, dwell time, and possibly just keeping perpendicular and coupled with the tissue. So the short answer is yes. The long answer is we're not exactly sure exactly when we're going to have this, but it's well along the process, and we understand that the design of the MP3 probe actually is leading to a lot of these problems.
Right.
And so we know, we've heard what the market is saying. We're trying desperately to get this as quickly to market as possible. I just can't give you any time frame at this point.
Yeah, I think that would revolutionize the whole process because I've done a few and I'm no good at it. That's why I'm here.
Yeah, there's one is the limits of each different anatomy and getting it in the right spot. But watching the view, I had a psychology professor in undergrad take people who had never played basketball and have their clothes arise and learn the muscle movement, and like everybody's hitting 3-point shot. Like it's amazing if you take some of the stuff out of it and kind of like the visual part or the pride part and have somebody videotape it. It's amazing. I just have my technician also tell me if I'm riding up too high or too low, or if I'm non-tangential. Sometimes it's useful to be able to spin kind of your hand a little bit so that you're maintaining exactly the same contact and angle. And if you don't force it, you can do a quarter at a time. And you can take it from one hand and pass it to the other. That's actually one thing I do. But having it submersed seems to be the biggest, like a physics thing that's, oh wow. Initially, of course, when you want to sell something, it's easy, but it's so easy that, baseball's easy too, but if you really want to get good at it, there's like a lot of different subtle things you have to learn about.
We've learned a great deal since the product launched, and so we are trying very desperately to get all of this information incorporated into kind of the next generation, so that we can make it much easier for you.
Yeah, because then it'll take off for sure.
We would like to think so.
Okay, my turn. Hi, I'm Jella An. I practice in University of Missouri and Columbia, Missouri. So we have a slightly different population. It's a tertiary center. So I do get more of those referral who's who's already max tolerant medication and already on 4 or 5 different medications, and they've been followed by general practitioner, either optometrist or general ophthalmologist for a long period of time. And then when they're ready for the surgery, then they come to me. So I have a limited option. But so that's why I'm here, because I want to give a different perspective about how broadly this laser can be useful. Thanks for having me, first of all, and being here. It's so early in the morning. I thought only the East Coaster would come here because you gain some time by coming here. But and then I think next time we can do a dinner meeting rather than a breakfast meeting. But anyways. This is I'm really grateful to be here because this is an opportunity to share my passion. MicroPulse, getting the MicroPulse in my practice was one of the best decisions I've ever made in my practice so far. Because you can use it for such a diverse, severity and type of glaucoma patients, and it's so safe. Of course, we're talking about the technique, and with the wrong technique, you can do harms, but that's so rare. And technique is totally doable. It's you just need a couple patients just to follow the steps that we have it here, and it's totally doable. It's nothing like if you can do cataract surgery, you can do this. So I will say, without further ado, these are what we're going to cover. So when I decided to go into glaucoma, my mentor told me, Jella, if you want to be a great glaucoma surgeon, you should think about moving every 5 years. Because all glaucoma surgery, no matter what it is, laser, drop, surgery, they all fail in about 5 to 7 years. And I'm like, okay, great. So I moved, and now I'm third year in Missouri. I have 2 more years to go. But I'm talking about this because now, there used to be such a huge gap between non-incisional glaucoma treatments such as the medication and laser, and the incisional surgery such as traps and tubes. But the MIGS came about 5 to 7 years ago, and a lot of us are doing the MIGS, and that's a great thing that the gap has really narrowed. But now we have a different gap here because the MIGS have been around for 5 to 7 years, and many of them are now failing. I don't like the word failing, but it's insufficient response. And there's some attrition rate as well with the Schlemm's canal procedure, for example. And of course, with the Zen, you can have a scarring, and patient doesn't want to do any needling or other procedure, so we do have a gap. So that's where the MicroPulse comes in. These are the patients who has had a MIGS, had a great result, but after about 3, 4, 5 years, their pressure starts to climb up, or they were well controlled on medication, 1 or 2 medication plus MIGS, but they can no longer tolerate the medication because of delayed hypersensitivity or change of the drops, or that national shortage of dorsal timolor. That was a disaster in my practice because almost everyone was on COSAL. So we got a lot of MicroPulse done on those patients. So this MicroPulse cyclophotocoagulation allows me to intervene earlier in the disease to reduce the morbidity of the progression and reduce the need for more aggressive surgery later on, namely traps and tubes. So I actually want to do a little myth buster because cyclophotocoagulation, we all have a bad experience, 1 or 2 bad experience with the cyclophotocoagulation, the continuous wave 1. So a lot of patients, a lot of practitioners, even though they have the MicroPulse technology, they are waiting they're reserving it for a refractory disease who should have gotten the CPC. They're like, well, you have a poorly controlled or refractory neovascular glaucoma, the vision is LP. We would have done the CPC, but let's try the MT-CPC first, MicroPulse CPC first. These are not the best candidates for MicroPulse CPC, just because, MicroPulse CPC is like a mix of traditional surgery. It is extremely safe, but at the same time, it's not going to be super aggressive. It's not your big gun. So you should really start thinking about using it much earlier than the typical cyclophotocoagulation candidates. All right. So myths or facts? MicroPulse CPC should be reserved for patients with a poor visual potential. we've already, Dr. Mahootchi did a great job and talking about how really it's so rare for a patient to lose vision from this laser if done correctly, but still it's it's still relatively much safer than any of the incisional surgery, including MIGS. So no, MicroPulse CPC should not be performed prior to filtering surgery because it causes a subconjunctival scarring. That's also a myth. I've done tons of MicroPulse CPC patients and followed by the Zen or traps or tubes. None of these patients seem to have subconjunctival scarring that impedes my subconjunctival procedures. So it really doesn't burn bridges for later surgery if needed. Hopefully never, but if you have to, then you don't have to worry about, oh, well, I'm gonna do the trap in this patient eventually, so I don't wanna do CPC. MicroPulse is a totally different animal. It really doesn't seem to either burn or scar or cause too much of inflammation, which brings us to the next point. MicroPulse CPC leads to significant inflammation, and most patients need a long-term steroid. After CPC, most patients are on steroid for at least a month, and you sometimes do Kenalog or dexamethasone injection. MicroPulse CPC requires very little steroids, so you use a Lotamax for 2 weeks. I use the prednisone for 1 week, or even none. To be able to, a lot of patients who are going for MicroPulse CPC don't want to use a drop. That's why they're doing it. So now I started doing the dexamethasone injections of Tenon, just like 0.1, 0.2 cc, and that takes care of it. And once I started doing the injection, you can bill for that too. Once I started doing the injection, I started seeing them a little bit earlier to see if their inflammation is well controlled. Nobody came back with the inflammation. You do see a couple of cells in the first few days. That's normal, even with the prednisone. But dexamethasone injection seems to be equivalent to prednisone for 1 week. Total duration of the energy delivery is the only variable you can control. Well, I do respect the fact that you said, do not change the setting. Yes, I do agree. If you're just starting out, or if you haven't done 20 cases, just stick with what Iridex recommends you, which is 80 second per hemisphere. So it's a 160 second in total and 2,000 milliwatts. However, all of those are variable, and the duty cycle, the techniques, everything is a variable. So I'm not saying that you should go ahead and change around, but just be aware, those are all variables that you have to be aware. Each time of the first case, make sure all the settings are correct, because maybe your partner was using it with the different settings, it may have changed. And we've seen that. Like one day I came in, I noticed, I'm so glad that I noticed, the duty cycle has changed. I don't even know how to change that, but someone changed it. And then they saved it. I'm like, oh my God, I'm so glad that I checked that. It's a 31.3% duty cycle. So check every settings. And I would say, just write down the setting and then just stick it on the machine so that you're always on the same setting. Because, like with the different setting, especially with the high setting, you can do some damage. This is, you can deliver more energy than the cyclophotocoagulation itself if you raise it high enough. So that brings down to the fifth myth. MicroPulse allows the cooling of the surrounding collateral tissue, therefore it's safe to increase energy setting until you hear the pop. That's how we do the CPC, right? We hear the pop and then we titrate it down. No, you do not need to hear a pop, and please don't do so. You don't need to titrate it. Only thing that I do differently now, I've done, I would have to say, 200 cases so far. Now I'm using slightly higher power. I'm not saying that you should do it, but in my hand, in my patient population, slightly higher power setting works better. And I'm publishing a paper on comparing different power settings. But I would say stick with what you're recommended, and then once you're comfortable with the several patient population, then you can start to increase it by little. So this is credits to Kevin. I think this is one of the most important things that you can print it out and stick it by machine, especially for if any one of you work with the trainee residents. These are the 9 points that I always go through each day. Even if it's the same resident, each day I go through them just to make sure that they understand how important each of these points are. you know, we talked about the energy setting, but the technique of delivering energy itself could be even more important in total energy delivery through the transscleral route to the ciliary body. So one of the most important things that Kevin keeps talking about is a liquid interface. When I first got the laser, I was told, yeah, you can use it because it's a lubricant. So it was like either take it or not. But no, this turned out to be one of the most important things, not to lose the energy to the surrounding. So you do want to submerge your probe in that liquid interface. I use lidocaine gel, 2%, so the patient is also comfortable. Probe orientation. Unlike the continuous wave CPC, which you point towards the optic nerve, this one you want to point towards the center of the eye, center of the globe. So you're always, imagine the center of the globe and you're going perpendicular to the ciliary body. Position from the limbus is of course important for all lasers. You want to protect the ciliary, the limbal stem cells. Always visualize about 1 millimeter from the limbus, and it's very easy to override the cornea. As we can see from the video and even my own video, it's very helpful if someone videotapes you. It is very helpful. And even now, when I see my own video, I'm like, oh, you know, like I was totally overriding that, or the probe was tilted towards the wrong direction. Pressure is also important. I think that goes with the liquid interface. You don't want to lose any power. You want to have a very firm contact. So Kevin talks about pen to paper. This is a pen that doesn't work very well. So not just a scribbling paper. You want firm pressure, firm contact through and through. Dwell time, very important. I think I was going too fast past 2 years. I used to spend only 10 seconds per hemisphere. So that gives about 8 to 9 passes if you're doing 80 to 90 seconds per hemisphere. It turns out if you go even slower, if you go double the amount of slow, if you spend 20 seconds per hemisphere, you get a better result. So I'm starting to do that thanks to Kevin. And you will realize how slow that is.
Yeah, it's really slow.
Spending 20 seconds per hemisphere, you feel like you're not moving, but you have to move. You don't linger around at one spot. But this is a very, very slow movement, but that also helps you to adjust your technique too, because it's going so slow. Always keep in mind, okay, 1 millimeter from the limbus, pointing towards the center, and firm pressure. Power 2000, duration 80 seconds to start with.
And there's a clock that's basically ticking on the laser. So there's some body view cues for you as you do the procedure. So every tick is 1 second, and then there's a call out every 10 seconds. So there's a voice that will say, if you have 80 seconds dialed in, it'll tick, 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 and then when you get to 70, it'll go 70. So you can actually follow that cadence, as you're thinking about the 20 seconds or 16 to 20 seconds per pass, and you're going back and forth. That cadence will actually help you follow that. And she's absolutely right. Compared to the way people were doing it much quicker, it is extremely slow. And it's going to feel a little awkward at first until you get that muscle memory. But listen to the clock, because it does help and aid in that cadence as you move back and forth.
It seems to be that you're weighing under effect. You didn't get the effect you want, versus you're worried about side effects that you don't want. And the timing is where it's at. If you're going too fast, you won't get the effect you want. If you go longer, the only case that I had that had some uveitis was the one where I went slower and I went slower and a little posterior. So if you're staying within that 15 to 20 seconds per pass, you won't get into trouble.
That's a good point. Actually, having the 1 millimeter from the limbus is important, but also you don't want to go any further than 1 millimeter either, because there's a lot of choroid there. So stay exactly where the ciliary body insertion is, which is exactly 1 millimeter.
And a fraction of the section won't kill you. It's just doing a whole treatment like that is where you're going to get in trouble.
Yeah, that's right. All right, I'll dare to show you my technique. I just created this for patients, because all of the patients asked me, like, oh, what exactly are you doing? And so I wanted to show them that this is what we do and how quick it is. Oh, it's going to play? There you go. So
I think if you click on your key, just put your pad, just put your finger once. No, just
Oh, I
on the
see.
fat pad. There you go. Now you're going. You'll, yeah. Just click on the star.
there we go.
I may not have sound, but that's okay.
Yeah. I don't necessarily do retro bulbar, but a peri-bulbar is a good enough in most cases. Most patients are doing this conscious sedation with the propofol in my ASC. So you apply the gel, you see how much of the gel that I've applied. Notch to the limbus and the flat side to the lid, and then we're going slow. Probably not slow enough here, but I'm really looking at the limbus to make sure that I have all that 1 millimeter gap from the limbus. 15 to 20 seconds per hemisphere. And I'm not using lid speculum. I find it much easier not to use a lid speculum because that flat surface also works as a retractor, and it doesn't get caught as you're moving around.
If they're blocked, if you ask them to open the other eye,
Mhm.
life is a lot easier. You get an extra millimeter or two.
Oh,
Because
I
when you're
didn't-
closing one eye, even if
Uh-huh.
you're blocked, the lids still want to close. Just open both if you've blocked one.
That's a good point. Yeah, avoid the 3 and 9 where the ciliary bundles are, and then we do the same on superior. It's helpful for your assistant to hold the eye at the inferior limbus and move it down to get a better exposure. I use a 0.12. You can use a ring forceps or Fechner if you don't want to tear the conch. But if you just hold it at the limbus, then it's pretty easy. So we're doing the same thing here. Superior can be a little bit more tricky, but as I said, not using lid speculum, find it easier. Also, I mark the little notch with the permanent marker. I put a big fat line there so I'm always in the right orientation. You want that line or the notch to be always facing the limbus. When you're, that really helps.
Do you change your orientation when you do inferior aspect versus superior? So move from, say, the superior point of the patient?
Oh, I see. I just changed my hand.
Okay.
Yeah, I use hand that's closer to the hemisphere. Yeah.
Don't feel that you have to stay in one aspect. You can move.
That's
because
right.
there's plenty
Yeah,
of
if
room
you
for-
prefer to use your dominant hand, yes, you can move around too. And you saw that it's not a sterile technique, you're not going inside of the eye, everything's on the surface. You don't need any sterile drape or anything. You can in fact do this at office very comfortably, but in office I do suggest that you do good anesthesia. I think a retrobulbar really helps in those cases. That patient was under conscious sedation with the propofol. And we do have a MAC, the anesthesiologist who's involved. So just want to go into cases now to see how we can utilize MicroPulse at all the gaps that we have in terms of our treatment paradigm. Our first case. We have time? All right. So this is a Miss SS. Now that's not her, that's a stock photo, but she looks exactly like her. Anyways, so this is a very sweet patient of mine. She's a Caucasian female, 78-year-old young. She's a very young 70-year-old who still works full-time as a biller at a practice office. Not ophthalmologist, I think it's a general practitioner, but she's a workaholic and she works out every day. And she's probably healthier than many of my 60-year-old. But anyways, the Shinas comes in because she wants to get the cataract surgery done. And her general practitioner said hey, you know what? You have a glaucoma, you're on a lot of medication, you don't like them. So why don't you go to a glaucoma specialist who can do a combined surgery? So that's why she's here. She says, I'm having difficulty driving at night and I really don't like all these drops. So we go, okay, perfect. She's been treated for the POAG for many, many years, had a very successful SLT in the past with a good response. There's no other prior surgeries. She does have allergy to BAK preservatives, so that's why she's on Travatan Z, alpha-GMP, and preservative-free COSUPT. She also uses artificial tears quite frequently. On exam, she has a perfect vision. She's wearing contact lens for the monovision, but she is symptomatic, having glares at night. IOP, not so much, not very ideal IOP, even despite the 4 classes, it's max meds that she can tolerate. Well, gonio shows that everything is closed. It's with the lens rise. And now she's starting to form early PAS in left eye. So, significant meibomian gland dysfunction, diffuse punctate epithelial erosion, probably from medicamentosa, a mild cataract, and 0.8 nerves. This is a hair visual field. Right eye is, I would say mild. Left eye, some of them is, it's a total deviation, so probably from a little bit of a cataract. Left side, kind of getting into the, center of the visual axis. So it's a mild to severe, possibly. So this is a 78-year-old with a mixed mechanism glaucoma, mild on the right side, moderate on the left, with presenting with a chronic vacomorphic angle closure with the now early PAS, with underlying POAG, poorly controlled on IOP on max meds, with the toxic keratopathy from medicamentosa, the mild NSC. So our plan was to do the goniotomy procedure with the cataract surgery, because goniotomy can also do a GSL, goniosynechiolysis, that she has. So that's what we did, and it went really well until 4 months later. She's coming in, I'm really happy with my vision. We did the monovision too. She's happy as a clam. But my eyes are getting more red and weepy. I think it's an allergy. Everyone in Missouri has allergy, by the way. So I'm like, okay. Vision is still good, 20/20 monovision. Pressure is good. We were able to already stop the co-cell preservative-free. But the eye looks like this. It's like, okay, it's brimonidine. Follicular conjunctivitis. So we're gonna hold the alphagen and see how you feel. So let's come back in 1 month and see how you feel. Coming back, it's really not getting better. I'm getting redness and irritation. It's actually getting worse. And I'm having lots of, light is bothering me. It's itchy. Coming in with this. I'm like, okay, well, it's 20/20. Okay, pressure is the 24, off again. Contact dermatitis, now she's only on Travatan, so it must be Travatan. I'm like, okay, well, we gotta get off the Travatan, but pressure's it's already bad. So we need something here. So we talked about, okay, are we gonna do the surgery? Or are we gonna give it a try with the MicroPulse CPC? And as soon as I said surgery, she's like, oh, no. First of all, I live 2 hours away. My husband just got into the nursing home. I need to take care of her. I'm working full time. I need to afford myself. How long am I gonna be off duty? And I say, okay, well, MicroPulse it is. MicroPulse CPC is, what I like the most about the MicroPulse, it's not just how well it works, but the fact that there's no activity restriction right after. They can go back to work right away, right? The vision's not gonna be blurred. No activity restrictions, there's no surgery, no additional drops. It's perfect for this situation. So that's where it comes in. So pre-op surgery, we always measure the pressure just in case. 27 and 30 off medication for 2 days. So we went ahead with the recommended setting. Week 1, vision 20/20, already 21. Now, I totally agree with you. It's very rare that you see the response before 5th week. Most people would need at least 1 month, if not 2, to get a maximal response. But many patients, though, it does start to decrease from day 1. Sometimes it plunges down and then come back up a little bit if you're using steroid because of the steroid response. But I would say that, I don't decide any major changes until about 5 weeks as well. So, okay, so 21, at least it's coming down already. Pressure 27 on the right eye. Let's just go ahead and do the right eye as well. 3 months post-op, she's 20/20 still, 15 and 18, off medication. All medication for 2 months. Significant improvement in the ocular surface symptoms. Of course, all the contact dermatitis went away as soon as she stopped the Travatan. Quality of vision has improved quite a lot, and she's no longer light sensitive. And she's been light sensitive for almost like all of her life while she was using all these medications. She's like, oh my God, I thought I was just light sensitive. But no, you don't have to be. She didn't know that she can be normal under the daylight. So she is happy as clam. Let's see if we have one more case. This is a Mr. PH. That's a stock photo, but he also looks like him. I don't know what's going on. But anyways, he's an 82-year-old sweet Caucasian male. He was referred to me by a general practitioner, general ophthalmologist, for visual field progression on the right side where he has a more glaucoma. He's been known for pseudoexfoliation glaucoma for a long time. He had a successful cataract surgery many years ago. He's healthy otherwise. He has a hypertension but otherwise healthy. He's on everything under the kitchen sink, you see, including pilocarpine QID. I don't know how he's doing it, but he said he's very religious, but he doesn't like it. He's on various BP meds, including the aspirin. On exam, his 20/25 OU, pretty good, but IOP again, not so good. 30 on the right side, 17 on the left. Yeah, he will be progressing at 30. Cornea was nice and open. Slit lamp is unremarkable. You can see most of the RNFL is now floored on the right side. Left side is not too bad. And that's what we see in the visual field. Pretty typical of a pseudoexfoliation. Right side pretty advanced with the, sparing about 10 degrees in the fixation. Left eye almost normal. So what do we do here? Well, I should have known better. This would have been a perfect candidate for MicroPulse CPC. But at that time, this is a very earlier in my practice, I'm like, you know what? You've never done the laser trabeculoplasty. You have a pseudoexfoliation that responds pretty good for laser trabeculoplasty. And we just got this machine, MicroPulse laser trabeculoplasty. Let's give it a try. But I did tell them, like, you have we're already starting from 30. If you get an IOP spike after LTP, then we have to go for urgent surgery. And he said, okay, no problem. I'll just do that because I will much rather do laser than surgery. So we did the laser that day on the right side. To my surprise, on second week, I don't normally see the patient at second week after laser trabeculoplasty, but I was worried about his pressure, so I saw him a little bit earlier. It's coming down. I'm like, okay, well, let's wait a little longer. At 2 months, I'm like, okay, well, it's working for you. That's great. Let's do the left eye. So we performed the laser trabeculoplasty on the left side. He's doing great at 3 months. So I'm like, okay, it's a happy ending, right? But now he's saying, now that my pressure is good, pilocarpine is giving me really bad night vision. He still drives at night. I'm like, can we stop that? And of course, he does have ocular surface disease, most likely from all these medications. I'm like, okay, let's stop it and see what happens. Pilocarpine was working. 42 and 22, still on 4 classes minus pilocarpine. And he's like, I really don't want to go back on pilocarpine. It's like the only option. So I was like, well, you just did a cold laser. Let's go notch up to warm laser. I use that analogy a lot. Cold laser being laser trabeculoplasty, warm laser being the cyclophotocoagulation. I used to use a cold and hot, but people don't like to put hot thing on their eye, I learned. So I say warm laser. So we are gonna warm it up. So he's like, okay, doc, let's do that. We did talk about surgery versus laser, which I wanted to just talk about. If any patient who are clearly surgical candidate without the MicroPulse. Before I had a MicroPulse, this patient is surgical patient, pressure 42, max meds. What are the advantages of a CPC, MicroPulse CPC to surgery, any surgery? No activity restriction, quick visual recovery, less frequent follow-up. I also see them 1 month or 5 weeks after surgery, the laser, and then 2 months later, which is the post-op month 3. No post-op drops with the dexamethasone. Minimal risk of infection or other surgical complication, especially in patients who have a high surgical risk. It's repeatable and non-destructive. Nothing is being destroyed here. Nothing is gonna scar. It's increasing the trabecular outflow. It will decrease the ciliary body influx, but we are not destroying anything, unlike continuous wave cyclophotocoagulation, which is destructive. It's very quick, under 5 minutes. Can do in an office setting if in a pinch. And then, as you can see, this advantage of the cyclophotocoagulation compared to any of the incisional surgery, by the way, is it does take time, 5 weeks. So if the patient is, in this case, like a 42, then that's why your discussion comes in. Like, can you wait 5 weeks for 42? But it's not that they're going to be 42, and then suddenly dunk. You know, it will slowly start to decrease. And this patient, it was like really against the surgery. I'm like, okay, we're going to do that. But, you know, if it was a young patient, I may have pushed for surgery if we are in a, you know, if a time pinch. Like, I always tell them, like, we are not doing, if the pressure is not well controlled to begin with and they're on max medication, I tell them, we are not doing the laser to get rid of your medication, we're gonna lower the pressure. If the pressure is well controlled on medication, then we are saying, okay, we are doing this to get rid of your medication. So you have to know that it's very hard to do both with the laser, the MicroPulse laser only. But, and also, I tend to under-promise and over-deliver. There is a risk of a retrobulbar anesthesia. You can do peribulbar, but I find that retrobulbar anesthesia does really increase the comfort level. And attrition rate is high. Just like the laser trabeculoplasty, it doesn't seem to last forever. You know, there's people who are going to come back after a year or two for a retreatment. We call it enhancement. But yes, we do see the attrition rate. All right, so this case, we are really going here because we tried the laser, we tried the medication and the laser trabeculoplasty before even going into MIGS option, because he's a pseudo-phakic too. We're gonna do the MicroPulse just before that. So we did the right eye MicroPulse. Remember the pressure was a 40. We used a recommended setting. Pre-op was a 42. Remarkably, he came down quite a bit on day 1. But as I said, we do see that. On day 1, you get very low pressure, and then it starts to climb up a little bit and then go down. He is on, you know, he didn't start back the pilocarpine. He's on 4 classes of medication. Month 1, it's very similar. Now month 3 goes back up to 34. What's happened here? This is the time when dorzolamide Timolurt went back order. And he said, like, oh yeah, I wasn't able to get one of the medication, the blue top, and I've been off 2 weeks. I'm like, oh, okay, well, now what do we do? So in Missouri, like, even dorzolamide was not available, Timolurt was getting short, so we're in a critical situation. So I'm like, you know what? I don't like retreating so early in the post-op period, but in this case, we're gonna give it one more try. Because you didn't have any problem, you had a good response, just insufficient. So we went ahead with the slightly higher power. I used a 2250 milliwatts. Everything else remained the same. The week 1, it was a 34, now 21, on Brimoni and latanoprost only. Month 1, similar. We changed the Brimoni to Combigan at this time because I didn't want to keep following up until the pressure starts to go down. Now you can argue, well, maybe the pressure was gonna fall down even more afterwards. It may have, but he was just tired of coming in every time. So I'm like, okay, you know what? You're fine with the 2 medication. Let's change the Brimoni to Combigan and see what happens. At 3 months, he's well controlled, 3 classes. He's happy to continue 2 bottles of medication. He's mostly happy that he's off pilocarpine. At 6 months, very good result. We just repeated visual field recently, very stable. So these are just, you know, these describe, you know, like the MicroPulse can be really utilized at any of the junction when you are considering, okay, this is a surgical patient. This patient needs more, or the next medication if the patient is fully controlled on already baseline medication. You can always give it a try. Happy clam. I just want to leave with you. This is a very short study that I did with my student. Wanted to see my 6 months outcome. It's a retrospective study of 77 eyes of patients who had at least a 6 months follow-up. And then we use an identical setting for all of these patients. Now, let's go here. since I'm in Missouri, most of my patients are Caucasian. 83% of the patient was included were Caucasian. So just keep that in mind. Most patients had a primary open angle. I also don't see a lot of uveitic glaucoma patients, thankfully, because I don't like uveitis. But I did have a 1 or 2 uveitic glaucoma patient who was not active. They had a uveitic glaucoma that was burnt out. I did do the MicroPulse CPC, and both of them had a great result without recurrence of their past uveitis. So I think it's fine, but I only have a limited experience with the uveitis. Maybe one of you have a lot of uveitic population and can do a little study, because I would like to know. That's a black box for me now. And the baseline IOP the mean baseline IOP was a 26 millimeters of mercury and on 3.3 medications. So this is what I saw. So this is a success rate. I define success as a 20% or more IOP reduction, or at least a 1 medication reduction. And without any additional IOP lowering procedures or medications. Success rate was about 70% on week 1. And in 6 months, it was about a little bit higher than 50%. And this is what I normally quote. This is my patient population with my technique. So this is what I quote. Like, in my experience, 70% of the time, or I say about 50% of the time, you're gonna reduce the IOP significantly, and or reduce medications. And most patients are, pretty content with that. Most importantly, now we're not always aiming, as a glaucoma specialist, we're not aiming for 20% reduction. I mean, do you even calculate 20%? I normally don't do that. What I want to get to is 18 or lower for mild patients, 15 or lower for moderate to severe patients. That's what we usually aim for. So how many of those patients actually achieve that? In my patient population, 50% of the patient achieved 18 or lower with or without medication at 6 months, and about a quarter of patients 15 or lower. So knowing this, if the patient requires a very low IOP, then I combine it with MIGS. And in my hand, goniotomy works the best. Now, I don't like actually doing it together, because after goniotomy, you do want a little bit of a high pressure to prevent the reflux hemorrhage in the first 2-3 weeks. So I don't want this to lower the pressure too much. So I like doing it in sequence. I usually do the MicroPulse CPC first, and then once they are stable from it, then I do the goniotomy procedure. If you're doing with the goniotomy, which one do you do first?
I did the Cyclo G6 first, then you prep the eye.
I see.
It's just, I think I would blow my brains out if I was a university professor. Here's why. If I have someone mowing my lawn and they're doing a terrible job, I don't hire a second company. I fire the first company. And then so that's how I feel about drops. If you're on 4 or 5 drops, somebody's been missing the point for a long time. So I've been saying 1 drop, 2 drop, MicroPulse. Like, never let yourself get into this. So that's why you're like at 50% success in the first year, because they're on all these drops.
Yes.
I'm in the 90%. And so I'm doing much more mild cases, but I have control over not having 4-drop craziness. You probably don't, because the referring surgeon
and many
has.
of my patients are angle closure too, so they're not getting benefit of the trabecular meshwork outflow.
Yeah, just people should be thinking about something else other than drops after 2 drops.
So that's why, again, that video I'm going to distribute to all the ophthalmologists too, saying like, okay, show this to your patient, see how easy and simple it is, and then refer patients early, because the earlier you get referred, the better response and more options. These are the mean medication difference was not significant. As I said, many of the patients were already on 3.3 medication, and many of them remained the same at 6 months. This is a Kaplan-Meier curve. This is what we're talking about with the attrition rate. In my practice, attrition rate, the estimated mean time to failure, that's going below what we targeted and requiring additional treatment, repeat treatment, or additional surgery, was about 39 weeks plus minus 2 weeks. So that's about 8 to 9 months. 22% of the eyes require additional procedure, and 8 of them require repeat procedure, the enhancement, and all of them received the repeat procedure with 20 to 50 milliwatts, and then that seemed to be successful. So that's why I changed my practice. So if all these patients, 10% of my patients are coming back for repeat enhancement, I'm just gonna start treating with the 20 to 50. And so far I've been getting great results. I have to say, I can count how many people who came back after 20 to 50 milliwatts of treatment, because it's that rare. So
That's awesome.
just quickly, other interesting finding was that there was no correlation between the age of the patient, baseline IOP, glaucoma types and severity, or the power of duration that I used back then with the successful outcome. So it seems to be independent of all these the demographic variables. And there was absolutely no vision-threatening complication, including CME, chronic inflammation, hypotony, and corneal edema. So, any questions? Yes.
I have a question actually.
Sure.
Are there any of the MIGS categories and products that you wouldn't use this on? Say you had a failed SiPass or an Ivantis, or is there any kind of components that would keep you from utilizing this technology to retreat if they were to fail?
I can't think of any.
I'm gonna put it in a van when I retire and just go around like the ice cream truck.
Yeah, I really can't think of any,
I do know that one of the things you don't want to do with this technology is do not treat over trying to think of the expression, the titanium alcon
Okay.
product. It
Well-
will absorb a lot of energy
Oh,
and
I
turn
see,
it into
yeah.
a big thermal heat sink. So just kind of in the back of your mind, if there is somebody with an expression, you want to make sure you don't treat over that. We also recommend not to treat over tube shunts or trabeculectomy.
Oh yes, yeah. I don't go to the bleb. Yeah. I stay away from the bleb. So even if it's not working, it's probably there's a thin area, and I just don't know how the transmission would be. So I go away from the bleb area.
I've gone over this one,
Cases,
no problem.
Yeah, really.
all of the presentations, I think, were pseudofakes. You do this in people who are faking, right?
Yeah.
Yes.
I mean, it doesn't cause cataract.
No, actually, it has not, which is, I didn't know in young people that was the choice. I mean, and I do everything. There's not anything that I'm not doing, but it hasn't done that, which is, it tells you a lot about the inflammation, but they're not going to get a cataract from it. That's
Yeah.
at
Well,
2,
it
3
really
years.
kind of goes from drops to SLT to MPC to Cahook to Zen.
Yeah, I don't.
After that, we send them to her.
Yeah.
Exactly.
You don't want
I do a lot of
once you have
investigations.
3 drops, the science says you're gonna fail. So if you're on 3 drops, you shouldn't be crossing your fingers. You should be like, let's how to get you back to 2, because you are going to fail, and you're just one shortage away from really ruining your day.
I
So
agree with you.
just
Yeah.
1 drop, 2 drop, MicroPulse, call it a day.
Yeah, or not even, I mean, it's
Yeah.
because it's so safe. I feel comfortable just offering it even before the drop.
I do too.
Yeah.
The injection you give in this medicine, how much, what's the brand name?
Dexamethasone, Decadron.
Decadron.
So I give about 0.1 to 0.2 subtenon.
Subtenon.
Yes, inferior hemisphere, and tends to last for 5-6 days, maximum week, and that seems to be good enough to take care of inflammation.
And there's some people who like recently you see in the ASCRS discussion was about using, instead of, if you're going to use Kenalog, instead of 40 milligrams per ml, use 10. And
I don't
spread
like
it out.
Kenalog because it lasts for like 6 weeks,
And
and you
this-
see the deposition.
So that's a good short. That's a good trick. Yours is a better trick.
Yeah, dexamethasone is good enough for this. I do use Kenalog for like
Cataract
traps and
surgery,
tubes.
yeah.
Yeah.
I'm very interested in this with regards to combining it with cataract surgery.
Yeah.
What's the pros and cons?
I mean, I do it. You do it. I do it right before the procedure, so that they come in. I do it, and then you got to get all the goniosol out,
Right.
and so that takes a little bit of extra time to make sure you got it out. I then take a Q-tip and make sure I get all the fornix.
Right.
Yeah.
And then we apply the betadine drop in there first,
Uh-huh.
and then we finish everything, and we do it again. Betadine has to dry to work.
Yeah.
So you just have to be efficient. One of the things I used to do, if I'm doing it on one eye, instead of doing the last drops of goniosol, if you're going to use, I use a drop of steroid, non-steroidal, and usually a Cyclo G6. And so that's my last lubricant drops.
Mm-hmm.
So you don't want to do that and then add lubricant drops. It's 20, 30 seconds,
Mm-hmm.
but on two eyes, a minute in the OR is, adds up over time. So those are like little tips and tricks.
Try lidocaine gel.
Yeah.
It washes out very quickly. Yeah,
better
goniosol is
than
tricky. It's sticky, so I don't like goniosol.
But it doesn't affect the cataract surgery. Then do
Yeah.
your cataract surgery and you're done. But you don't want to do this
There's
after the
one
surgery.
caveat to cataract surgery too.
Okay.
So we do recommend it before, not after, just because you get a pressurized, kind of anatomically normalized eye to treat. But if you use a femtosecond, that suction ring is going to create a little ridge and a lot of eye injection conjunctivally. So the only thing I say is if you've got a really red eye or you have this situation with the femto, a drop of neosynephrine or a drop of iopidine, or just trying to blanch those vessels out and get it as quiet as possible, because hemoglobin, both oxygenated and unoxygenated, are a chromophore for this wavelength, so they're going to absorb energy. So if you've got a subconjunctival hemorrhage or just a lot of tortuous vessels, you want to make sure to try to blanch those out before you treat, because it's all about getting all of the energy possible into the tissue you're trying to treat, as opposed to having it absorbed by other chromophores along the way.
Good point.
Yeah.
Gotcha. So you need to be very
Lumify.
fastidious.
I'm sorry?
Lumify, the over-the-counter Lumify drops, those things work in 3 minutes, and they make the eye white as snow, and you just put a drop of Lumify in.
I mean, because a lot of the eyes you see, they're red and meaty and kind of not real fun.
Yeah.
And, that's a lot of energy you're going to waste, just trying
That's
to
why don't put yourself in that position.
Yeah. Exactly.
Well, cool. Thank you
Okay,
very
thanks,
much.
everyone.
That was fantastic.